Okay. Thank you everybody who's joining us live for the final nutrition career talk of the 2026 academic year. Very, 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 very excited and grateful to welcome Lara here to speak about her career as a clinical dietitian at Children's National Hospital and give us a mini lecture on the nutritional management of neurological disorders. So I will let Lara take it away with an introduction.
All right, yeah. Hi, everyone. So I'm Lara. I'm a clinical dietitian at Children's National. I finished my PhD at Oregon State, and while I was there, I completed my didactic coursework. After I finished at Oregon State, I moved on to NIH, and I'll tell you a little bit more about my timeline. So I have I think, a pretty varied background. I did not originally start off in nutrition. I graduated from Smith College with a bachelor's degree in anthropology in 2012. And at the time, I was really interested in early domestication, that transition from hunting and gathering to agriculture. I did some archaeological research as an undergrad, and I was also a student athlete. And I spent a lot of time thinking about nutrition. I was diagnosed with celiac as a sophomore, and I was just very interested in nutrition, but we didn't have a program. So after I graduated from college, I took some time to kind of think about what I wanted to do, and a local university opened up a nutrition graduate program. So I ended up enrolling at George Mason in 2014, and I quickly got involved with research there and loved it. I did a thesis looking at differences in nutritional intake and bone health among adults with and without celiac disease, and I used data from the National Health and Nutrition Examination Survey to complete this work. I really enjoyed the research I did, and I knew that I wanted to continue doing research. So after some time working, I ended up going back to school again, this time to Oregon State, and I completed a dissertation examining the relationship between IGF-1 and bone turnover in a non-human primate model of voluntary alcohol consumption. And I did this under the guidance of Ursula and Russ at Oregon State. So after I finished at Oregon State, I went on to complete my dietetic internship at the National Institutes of Health. So interspersed with the education is also some, I think, pretty varied work experience. So after I graduated from college, I worked as an English teacher briefly in South Korea. And when I came back, as I said, I was really not sure what I wanted to do with myself. But like I said, I was an athlete in college, so I decided to start working as a personal trainer, which is something I had to get a certification for. And I worked in kind of various settings. I also did some rowing coaching for a high school in the area and enjoyed it. This kind of brought me over until I started at George Mason to do my master's. Meanwhile, I ended up getting a job at a trade organization called National Court Porters Association, and I worked as a program manager. I kind of fell into that job. I was looking for something, and I ended up with a temp agency. And my very first assignment, within a few days, I was offered a full-time position. So I had that job for about 2.5 years, and that carried over the full time that I was at George Mason. As I said in the previous slide, I did a thesis using enhanced data, and this opened up an opportunity to work at the USDA with a department that's responsible for the dietary intake component of NHANES, which is what we eat in America. So I worked at the USDA for 2 years as a nutrition research scientist after finishing my master's degree. And this was really where I realized I wanted to pursue a career in nutrition research. I was working alongside a bunch of PhD RDs. I was one of the only people who did not have an RD at the time. And so I was very influenced because I liked the perspectives that they brought. So that's kind of when I made the decision to return to Oregon State or enroll in Oregon State and complete my PhD in nutrition, but also at the same time complete my didactic coursework to make me eligible to do a dietetic internship. I worked as a graduate research and teaching assistant, so I taught some classes like Intro to Nutrition for majors, the Lifetime Fitness for Health class, Food and Non-Western Culture, and I think a couple other classes interspersed in there. I really enjoyed teaching, and I also enjoyed the research side of it, so I felt like I got kind of the best of both worlds. And as I finished the didactic coursework, I knew that the next step for me was to complete a dietetic internship. And I felt very fortunate to be selected into the internship at the National Institutes of Health. And that program is very research focused, but the actual concentration is clinical. So it's a 44-week program. I completed 22 hours, or not 22 hours, 22 weeks of clinical rotations. And as I was finishing up my internship, at the time, I thought that my next step would be to complete a postdoctoral research fellowship. So I had secured one, and unfortunately, it fell through. And at the same time, I was offered a opportunity to stay on at the NIH as a clinical dietitian. So I accepted. And I enjoyed it. I think it was really good experience. I was working with adults, but for various reasons, it wasn't the ideal fit for me. And that's kind of a message I just want to impart that it's okay that, your first position might not be perfect, and it's okay to change. So I ended up, after that, moving on to Children's National. I never thought that I would end up a pediatric dietitian, mainly because I was intimidated. I think that I was worried that it would be a really sad area to work in. Um, but I also really like children, and I have a couple of my own. And so I had a friend, a former person who was also in my internship who ended up at Children's. And as we talked about it, it sounded like it would actually be, I think, a really good fit for me. It's an academic hospital, so that means that there's also research there. And so it was an opportunity, I think, also for me to merge both of the areas of my interest, the clinical and the research. So most of my job is clinical, but I also do some research. We have a research committee at Children's National, and anyone who's doing research at the hospital, and there's so much research going on that has a nutrition focus, may reach out to our nutrition research committee and ask if someone could, on a consultative basis, help out with their research study. So I jump on that when I get the chance. One of the first studies I worked with was examining the timing of initiation of nutrition support, so enteral nutrition, on length of stay and long-term outcomes for patients with a mucocutaneous condition, which makes it very difficult for them to eat. And it's something that is transient, so it's not a permanent thing. But when people get this, it hurts for them to eat. So we wanted to see if early introduction nutrition support could help reduce the duration of their condition by optimizing nutrition status and also length of stay. So we're still writing up the results of that. And kind of fast forwarding all the way to now, I also have a study that we are submitting to IRB in the next, hopefully, couple weeks. So yeah, it's a little bit of both worlds. Let's see. So I guess I could walk you through a typical day at Children's for me. My main coverage is with our rehabilitation and specialized care program. So I'm actually at a separate facility that's just down the road from the main hospital, but I'm part of the inpatient dietitian pool. So I also provide cross coverage at the main hospital with all sorts of different departments. My patients are typically under this kind of bracket of what's called complex care patients. So these are children from birth to 22 years of age who often have multiple medical conditions and tend to be in and out of the hospital. Many of them are trached. Almost all of them are on tube feeds or parenteral nutrition. I think, I have a typical census of about 20 patients that I follow throughout the week. And I think right now I have about 4 patients who eat by mouth. So I do a lot of nutrition support for what I do. Um, the conditions vary that I see. So aside from complex care, I also see patients who perhaps were in a motor vehicle accident and are coming in for intensive rehabilitation with physical therapy and learning how to eat again. I also get babies who maybe have RSV and stop eating, so they get a tube and now need to do intensive speech therapy to learn how to eat again. And so I'll work with them on weaning their enteral nutrition as their PO intake improves. So I see quite a bit of kind of, yeah, the speech therapy enteral wean aspect. And on a typical day, I tend to come into work at about 7:30. And I usually will go through my list of patients, kind of figure out what my plan is for the day. By around like 10 a.m., I'll head into rounds, and that's interdisciplinary. So we have all members of the team, and that can last about an hour, which is pretty short compared to other teams that I've worked with. And after rounds, I will typically go see a few patients. I'm not doing a lot of counseling in my role, but maybe I'll check in if their parents are there, see if they're noticing any concerns, any issues, toleration of their feeds that need to be addressed, or I might share updates if we're making changes to their regimen. And then my afternoons are mostly spent in family meetings. And so all the members of our interdisciplinary team will sit down with the patient's parents or caregivers, and we provide updates. So we share kind of where they are, what their goals of care are. Our patients often come for a few months, so they're with us for quite some time. So we'll talk about how their progress is and how ready they are for discharge and what their needs might be after discharge. So it's a pretty interdisciplinary focus. I work with members of all sorts of teams, and I really enjoy that.
I'm just gonna we're making really good time. So, and you're gonna go into a mini lecture. Does anybody have any questions that pertain specifically to Laura's education, her career, her day-to-day before she jumps into the mini lecture by chance? Open the floor.
And I'm not really sure how to word this, but when talking with, parents or caregivers, I'm wondering, especially for children, you probably see like, multiple times, and going to the hospital is very much a regular part of the routine. So I'm kind of curious like how you can, help like facilitate conversations with parents who might be worried about, maybe their child might not be having their like quote unquote normal childhood because of their condition. So like how would you like handle that conversation?
Yeah, I think that that's definitely something that I would loop the team into because we have other members of staff that I think would be more suited for that kind of conversation. So we have social workers, we have psychologists on staff, and those are people who I think would really be able to handle kind of the psychosocial aspect of those concerns. But for me, as a dietitian, I think where that comes into play is parents who are concerned that their kid is not eating food in the way that is most natural or expected. I think that, food is culture, food is, the way that many people share or show their love. And so for families, it can be really difficult for them to see that their kid is not able to eat. Perhaps it's a baby who has difficulty swallowing. They are at risk of aspiration, so they're on tube feeds. And it just really concerns them that their baby is just not able to drink a bottle of formula. Or it's a family that has a slightly older child who had an accident, some sort of neurologic devastation, and is no longer able to eat and now is relying on tube feeds. And it makes them sad that their kid is just not able to eat the things that they used to enjoy. And so for those, I would say I struggle with those quite honestly. I try to shift the focus on, you know, what we're doing to meet the kids' needs, that they're growing, kind of sharing the successes, right? So if it's the baby that's not able to eat, if they're at that point, they often have had some weight loss or kind of growth faltering by that point, unfortunately. And by that time, they come to me and they work really closely. We get them back to a point where they are growing well. And so I'll focus on that. Like, yeah, it is devastating, that your kid is not able to eat or drink a bottle or do something that, is just expected or normal for a child. But look at the success and this progress. And, if it's a kid that's making progress with being able to eat by mouth again, then I highlight that as well. But yeah, these are conversations we have, and those are definitely conversations that I would clue in the social worker and, psychologist, because they would just be better equipped to kind of have those conversations than I would be.
All right, cool, awesome. Thank you.
Absolutely.
In the beginning, you were talking about how the RD perspectives influenced your choice to go into becoming a registered dietitian. What was their perspective that they brought?
Yeah, I had kind of distinct moments, right? So, um, I think being in the research, kind of nutrition research space, I picked up on sort of a tension between people who were, nutrition faculty and had the RD and those who didn't. I kind of heard, complaints that sometimes nutrition research is sensationalized. We have media articles coming out saying, if you eat this, it's really bad and does this awful thing to your body, but it's based on research that was done in rodents that gave doses that we would never be able to take. And so because I kind of picked up on kind of that tension, and that's not to say, nutrition faculty or researchers who didn't have the RD were not producing quality research, but because I kind of picked up on that tension, it kind of made me gravitate toward wanting that training for myself. I remember when I was doing my master's defense, we had this kind of distinctive moment where we were talking about, the bone health, and we had limited data. We looked at DEXA scans, and I remember my professor was kind of asking me to dig deeper, like what are some other things that, if you had control over this research, you would look at. And I don't know, it's a really good question. Trying to think about what really it is. I think I think this ability to kind of think about what's realistic and what people are really eating, and kind of just this experience and working with people closely rather than just kind of this theoretical, like, okay, do this, don't do that type of thing. I guess there's just a lot of nuance to diet.
So it was the application of like feeding people or knowing what you're researching, but also how to apply it to everyday
Yeah,
people.
and kind of translating science.
Okay, thank you.
Yeah.
I just have a question, Lara, about um, burnout
Hmm.
or how you manage balancing what sounds like very intense work with families and children.
Hmm.
And um, and then if you ever have feelings of imposter syndrome or anything like that, and how you might mitigate or manage that.
Yeah, good questions. So I'll start with burnout. I've always been a really big believer in work-life balance. And so I think, it looks a little differently. We talk a lot about that with my department. We have 35 of us dietitians between inpatient and outpatient. For me, work-life balance really looks like I get to work at 7:30 and I leave at 3:30. And sometimes there's a little bit more work that has to come home with me, but I make sure I'm out the door at 3:30 on the road, able to be the one who picks up my kids from daycare. And that's just something that's really important to me. Um, I think that having outside like hobbies is also really important to me personally, and it helps with kind of preventing burnout. So for me, fitness is really important. I really like running, so most mornings I'll go to the gym before work. And it's a added bonus that I go to a gym near work, so I kind of beat my commute a little bit. It's a faster drive if I leave earlier, which also plays a role in the burnout for me. And then just also taking the time off. I think, going on vacations or taking days off when you need them, I'm a firm believer in a mental health day. I think that there is a lot of value to recognizing when you need a break and taking it before things build up. When I was younger, kind of in my mid 20s, I remember just overcommitting. I had mentioned that, I worked full time while doing my master's, and I also kind of held on to a rowing coaching gig and was volunteering with another organization. And that for me was the point of burnout. And I remember just kind of sitting down with all my commitments on a piece of paper and be like, this is what I need to keep. This is what needs to go. And just kind of figuring out how to prioritize that time was huge. And then the other question, sorry, I'm trying to remember what the other question was now.
Related to like feelings of imposter syndrome and
Imposter syndrome. Yeah, I definitely have had that. I had it when I started at Oregon State. And I think for me, because I didn't have that same nutrition background as maybe some of my peers coming in did, that I was an anthropology major as an undergrad and less like bench science, kind of heavy, hard science. I remember being so nervous about impressing the people I was around. Some of that, quite honestly, went away for me when I had my son. I had him in the last year of my program. And I remember just sitting on the couch with him, like sleep deprived, writing my dissertation, and I was just too tired. And I also started producing stuff that my advisors received way better than they did prior to me having my son. And it had nothing to do with them being nicer, but I just stopped caring about being meticulously perfect, which is impossible to achieve, right? And I would just like dump my thoughts on paper and or into a Word document, and that really helped me. Um, I'm not sure that I could have achieved that epiphany sooner or how I could have, but yeah, and I still kind of feel it sometimes, when I enter a new setting, and I think we all do.
thank you. I appreciate your last comment about like not being as meticulous. I'm literally working through that on a project right now. So
Yeah,
yeah.
it's so hard. One thing I used to do, like if I was writing a paper and I couldn't figure out how to write something, I get this like word or like a word block, and I started just like writing what I could. And if I couldn't think about what next, I'd put like underscores until I figured out what to pick up. And that just kind of helped me like move through it until I figured out what to do because I would just stall. I'd be like, I don't know what to do. I don't know what to do. And it was so hard. Um, so yeah, strategies. It's hard.
Um, we'll start the mini lecture. I'll swap over to you in a second here. Um, Laura will give a brief lecture. I'm super excited for it. And then we'll still have hopefully like 15 or so minutes for Q&A, and that can obviously relate to Laura's education, her job now, and of course the mini lecture too. So if you have some questions, definitely save them, ruminate a little bit. But I am going to stop sharing now and then have Laura take over.
Right? Okay, can you see it?
Not yet. Yeah.
Okay, great. Okay, so I am going to give a mini lecture, and this is derived from a presentation I actually just gave a week ago. At Children's, we have an annual nutrition symposium focused on pediatric nutrition. And I co-presented this presentation on the nutritional management of pediatric neuromuscular disorders with a couple of my colleagues. So one is a physical medicine rehabilitation physician named Melissa Fleming, and then one of my dietitian colleagues, Sabrina Riordan. And we both see patients with neuromuscular disorders, but at kind of different stages of their journey, where usually by the time they come to me, they're on nutrition support. She usually sees the patients when they're a little more ambulatory eating and kind of working on promoting the PO intake. So it was very fun to kind of work on all stages of their management. Then let me try to advance. All right, can you see the next slide? Okay, good. All right, so for this presentation, I'm going to start off with an introduction to pediatric neuromuscular disorders, really just trying to orient all of us to what these conditions entail. And then I will move on to the nutritional management, starting off with how we conduct our nutrition assessment, and then common complications of neuromuscular disorders and special considerations that we need to consider as the dietitian. Neuromuscular diseases or disorders are divided into problems with the central nervous system of the brain and spinal cord or the peripheral nervous system of the nerves that start in the spinal cord and along to the muscles. Neuromuscular disorders specifically are diseases of the peripheral nervous system or muscles. So anything that's along the motor neuron or motor unit. We can divide this into lower motor neuron lesions and then upper motor neuron lesions. But for the neuromuscular disorders, we're really looking at the lower motor neuron phenotype. So this typically presents with weakness and paralysis, low to completely absent muscle tone, low or absent reflex strength. We see muscle wasting that can be very rapid. And there can be a variety of causes of this. This might be motor neuron disease, spinal cord injury, peripheral nerve dysfunction, and so on. So I'll focus on a couple specific examples. Upper motor neuron lesions tend to present quite differently from the lower. So we do see weakness and paralysis, but where with the lower motor neuron lesions, we tend to see lower absent muscle tone. For upper motor neuron lesions, we see increased muscle tone. We see increased reflex strength, and muscle mass tends to be maintained. So to really visualize this, I have a couple examples that you may or may not be familiar with from kind of popular media. So on the left, we have Shane Burkha, and he maintains a popular Instagram account called Squirmy and Grubs. He has spinal muscular atrophy, and he's a very classic phenotype that we would expect to see with this disorder. So you can see in his legs that there is profound muscle wasting. There's really not much tissue on his lower legs or his arms. He is wheelchair bound, and this is not because there is a nutrition issue for him. This is not a lack of intake. He is not malnourished. He just has a profound loss of muscle tone. So he's a very classic phenotype of what we're talking about with the neuromuscular disorders. On the right, we have an actor, RJ Mitte from Breaking Bad. He has cerebral palsy, so that would be an upper motor neuron lesion. And that's really not what we're talking about with these conditions. For him, you can see that his muscle mass is maintained quite well, to a point where he is actually a model. Um, but he does have muscular disorder, and so he has an altered gait kind of pattern. So there's still stuff going on, but he really is not the phenotype that we're talking about for the neuromuscular disorders. There are various classes of neuromuscular diseases. So for today's presentation, I'm going to focus on two specific conditions. I'm going to focus on spinal muscular atrophy, which is a motor neuron disease. And I'm also going to look at muscular dystrophy, which is a type of myopathy. So starting with motor neuron diseases, these affect the motor neurons, which are the nerve cells that control voluntary muscles. And this can result in impaired signaling from the brain and spinal cord to muscles. And key features that we would see include muscle weakness with nerve involvement, muscle atrophy, muscle twitching, and these conditions can be very progressive and severe. One type of motor neuron disease is spinal muscular atrophy, or SMA, and this occurs as a mutation in the SMN1 gene. There are various phenotypic expressions and four types that we can categorize. So type 1 occurs during infancy, and it's severe. Most patients that have type 1 often do not survive infancy. Type 2 is intermediate, type 3 is milder or later onset. And then type 4 tends to not present until adulthood. So these are not, patients that I would be seeing as a pediatric dietitian. Incidence is estimated at 1 in 10,000 live births, and all states, including DC, now include SMA in newborn screening, which is a great progression. Another type of neuromuscular disorder is myopathy, which is a neuromuscular disorder where the primary symptom is muscle weakness. And this occurs due to a dysfunction of muscle fiber. For patients with myopathies, we tend to see muscle weakness that really tends to affect proximal muscles like our hips and shoulders. There tends to be little or no sensory loss, none of the muscle twitching that we see with SMA. It could be inherited or acquired, and it could be non-progressive, slowly progressive, or rapidly progressive. When conducting a physical exam in myopathies, we will typically see this proximal muscle weakness and a myopathic gait. So where the muscles that are more proximal are weak, like our hips, they don't have that musculature in their pelvic floor to be able to walk with a very traditional gait of kind of moving your legs forward. So there might be some swinging from side to side. Myopathic muscles, you might expect to appear atrophic, but they can also be pseudo-hypertrophic. And so in that picture, you see a very bobular calf in a patient with a myopathy. And this is actually not true muscle. So if you're doing a physical exam, it might look like he has significant muscle mass, but there's really none in there. They do have normal sensation. They tend to have hyporeflexia and hypotonia, and this results in kind of a floppiness of their limbs. And the altered musculature can lead to abnormalities in bone alignment, joint contractures, and scoliosis. They also tend to have impaired respiratory muscles. The musculature is affected kind of systemically, and this leads to a weak cough. One type of myopathy is muscular dystrophy, and that's an inherited myopathy that's characterized by progressive degeneration of skeletal muscle fibers. This occurs due to various genetic mutations, and the body is just not able to maintain muscle fiber homeostasis. The degeneration outpaces regeneration, and it can be slowly progressive, but typically the prognosis is poor. There are two broad types of muscular dystrophy, Duchenne and Becker, but it really is a spectrum of muscle disease. So Becker, we tend to think of as being mild, and Duchenne tends to be the more severe phenotype. So moving into the nutritional assessment, we would really start with the same type of assessment we would do with any patient population. We're going to collect anthropometrics, so weight, height, or length, depending on the age, which then we would use to calculate BMI, or weight for length. It can be difficult to assess anthropometrics in patients with this population. So if they have kind of deformities or are just really not ambulatory, it can be difficult to measure their height. So we might use alternative calculations that allows us to approximate what their height is, including ulnar length or kind of the lower arm. Their ambulatory status can also impact weight measurement methods. It can be difficult to get them on a scale to be able to properly weigh them. We would conduct a nutrition-focused physical exam, but keeping in mind that the way they present with a hypotonia or kind of the false pseudohypertrophy, the results of this might be misleading. But over time, if you're seeing a patient over time, you can track changes that way. We'd want to collect a diet history, any labs. Bone abnormalities are common. So typically these patients, at least at children's, are going to have DEXA and bone age scans, as well as any additional screenings or special considerations. When we estimate nutrition needs, we're following a very similar process as with other patient populations. So for energy, the gold standard is always indirect calorimetry, but getting this can actually be unrealistic due to just kind of availability and cost constraints. So we tend to turn to predictive equations, and there's not a validated equation for this population, but we tend to use Schofield equation, which requires height and weight, or WHO, which only requires weight, so no height is required. For protein, we're using DRI for age, and there's really not evidence to support using increased protein intake for this population. And then for fluids, we would typically use a Holiday-Seeger equation, which is pretty typical for any pediatric patient that we see. And this is a useful method for them because it's weight-based, so we don't need height for the equation. But even though where we start is very typical of all populations, there are some special considerations when working with neuromuscular disorder patients. So these include over or under nutrition, feeding and swallowing difficulties, GI symptoms, medication interactions, as well as body composition and metabolic concerns. So I'll go through each of those individually. Starting with overnutrition, patients with neuromuscular disorders are at risk of undernutrition because their calorie needs tend to be a little bit lower. That reduced muscle mass reduces also their energy expenditure. They tend to have decreased physical activity, and this also decreases as they become less ambulatory with disease progression. However, we tend to see that these patients are put on steroids for long-term management, and this can cause increased appetite, as well as a very common issue, I think, for any population with difficulty understanding portion sizes. Just as they're at risk of overnutrition, undernutrition is also a concern that they have decreased muscle strength, and this can make eating difficult. We might see dysphagia or chewing and swallowing difficulties, as well as GI symptoms impacting intake. Because of their weakness or fatigue, we may see prolonged meal times, which makes eating a burden. They may need feeding assistance, as well as increased energy requirements. So I said on the previous slide that their energy expenditure is lower, but when patients go into respiratory failure, their lungs are expending much more energy just to kind of maintain kind of their baseline. and this can cause their energy requirements to go up. Feeding and swallowing difficulties are very common for these patients. They have weakened oropharyngeal muscles, malocclusion, macroglossia, which can all lead to swallowing difficulties. As a dietitian, we might want to consider whether there's difficulty swallowing food very broadly, whether food is adhering to their throat. So patients might not realize that they're having difficulty swallowing, but they might notice that food is just kind of sticking there. So if you think about when you're eating like peanut butter and just kind of sticks in your throat, this can happen with foods that you would expect to go down much more smoothly. And that's just from that weakness of the muscles, so that it's harder to propel the food down. We also would want to assess the average time to eat and quality of life. Are they spending hours trying to finish a meal? Is this impacting their quality of life? These patients typically would want to be followed by a speech therapist who would be suited to assess whether they are having impaired swallowing. We can introduce different feeding techniques to help them promote PO intake. So this may include adopting using adaptive utensils like special spoons and cups that aid in self-feeding. We do again want to monitor eating pace and fatigue, use strategies to meet calorie and protein needs when overall intake is limited. So our kind of go-tos here are our small frequent meals, ensuring meals are nutrient dense to really get the most bang for your buck, and ensure using snacks and oral nutrition supplements to optimize calorie intake. We also may encourage patients to sit upright or semi-upright during meals. And this is really to prevent aspiration to help kind of encourage food to go down as their muscles are weaker. Texture modifications are very common, especially as their swallowing difficulty progresses while they're still able to eat. So we at Children's use what's called the ITSE diet. And so that is just a kind of classification system for different texture modified diets. So for patients with severe dysphagia who are still able to safely eat something, they might be put on a pureed or soft food diet, or they might be at kind of higher levels, kind of gradually getting closer to what we would expect to be like solid foods, so like moist, cohesive foods, soft and bite-sized to relieve chewing burden. I wanted to put in a note that, thickening agents have been used for this population in the past, but we've really moved away from that because they tend to increase oral phase problems and pharyngeal residue accumulation. Moving into GI symptoms. So constipation can be a problem, especially if patients are less ambulatory. There's less movement to help kind of promote or stimulate bowel movement. And so as a dietitian, we really want to ensure that they're getting adequate hydration and adequate fiber in their diets. Patients often will still need a bowel regimen. And so that's something that we can kind of monitor as dietitians and recommend to the team if we think that a patient would benefit from a reassessment of their bowel regimen. Reflux is very common. And so, normal interventions, we might have them limit citrus, spicy, greasy foods, also encouraging them to avoid laying down immediately after eating just to let food kind of settle down. And then delayed gastric emptying, food kind of just sits in there. So for that, we would recommend small, frequent meals. We also see medication interactions which impact their nutrition status. So as I said, they tend to use corticosteroids over the long term. And side effects of this would include weight changes, growth suppression, short stature, osteoporosis and bone health concerns, Cushingoid features, behavioral changes, as well as hyperphagia and appetite changes. So moving into bone health, and my background is in bone research, so I couldn't, not include a slide on this. It's very common to see osteoporosis at a very young age in this population. And this tends to be very multifactorial. So I mentioned that, long-term corticosteroid use is a risk factor for this. But we also see hormone imbalances, so reduced growth hormone, altered testosterone, as well as vitamin D deficiency. They have a loss of ambulation, so they're not getting that mechanical loading that's really necessary for maintaining bone homeostasis and building bone. We see vascular dysfunction, genetic factors, and inflammation. Along with osteoporosis, fragility fractures may occur. We see scoliosis, that altered musculature, impacting kind of joint architecture, growth retardation, as well as fracture-associated fat embolism due to the vascular dysfunction. As a dietitian, we really can't prevent skeletal complications, but we can try to optimize where we're able to. And so for that, we really are just making sure that they are getting adequate vitamin D and calcium. And they will often need aggressive vitamin D. So we're looking at 50 micrograms or 2,000 international units daily to reach adequate levels of 25 hydroxy vitamin D. And for this, because our scope is pretty limited, we'd be working in a very multidisciplinary team to ensure bone health. I know at Children's we have a special bone health clinic to handle that. And then lastly, we're also looking at body composition and metabolic concerns. So we see a profound decrease in lean muscle mass, which is accompanied by an increase in fat tissue. And so this repetitive cycle of muscle degeneration and insufficient regeneration leads to a progressive loss of muscle tissue that's replaced with adipose tissue. As a result, we may see insulin resistance. So we know that muscle is the primary tissue that's responsible for insulin-mediated glucose disposal, as well as low physical activity levels can lead to lower energy expenditure and reduce insulin sensitivity. We also see dyslipidemia, so medications can cause this, as well as the reduced mobility. And then cardiac complications are a concern. So on top of just general heart health concerns that come with increased adiposity, dilated cardiomyopathy and arrhythmias are quite common. So as dietitians, we are going to encourage nutrient-dense, balanced meals, limiting saturated and trans fats, emphasizing unsaturated fats and omega-3 fatty acids, minimizing added sugar and sodium, encouraging increased fiber intake, so getting their fruits, vegetables, and whole grains, and ensuring adequate protein intake. So we want to encourage lean protein sources. But remember, we really don't see sufficient evidence to support having higher levels of protein intake in this population than what is the expected norm for their age. So really promoting a heart healthy diet is kind of the way we approach nutritional management. But as I touched on, as the diseases progress, patients may not be able to eat, and so nutrition support may become indicated. On top of this, so this might be due to dysphagia, so if it's unsafe for them to eat because of a high risk of choking and aspiration, or if they're just not able to take in enough as they're getting tired while eating, they have increased needs, or a loss of ability to self-feed. We may start to consider initiating nutrition support. When we do this, we'd be typically giving formula. And so our choice in formula really just depends on the patient's specific nutritional needs and tolerance. We typically would start with a polymeric formula. There's not really any reason in a very general sense with this population to suggest that they need anything hydrolyzed or otherwise broken down. But we would be considering common issues of constipation, delayed gastric emptying, and reflux. So if they have constipation, making sure that there is adequate fiber and also hydration. And sometimes medications or prokinetic agents are needed to maintain tolerance and nutrition support. So typically when I see that, I've kind of gone through multiple interventions and a patient's still having kind of issues, kind of emptying. And so I might talk to our provider and ask him if he's considered a prokinetic agent. That's not something I could, you know, um, put him on myself, but it could be something I recommend. With patients who might end up on nutrition support, we really want to maintain or manage expectations with the family and caregivers. We try to start having those conversations early just so that they know that that might be something that is needed down the line so that they're not hit by this surprise. A question that came up earlier was how we kind of talk to caregivers when they are sad about, a loss of a normal childhood. So expectation management really helps with those conversations. And then just one other consideration, as I touched on, gastric emptying can be an issue with this disease, and it worsens with disease progression. And so even though we might start with like a gastric feed, we may need to move into a post-pyloric feed as this progresses. So with that, I'm happy to open up to any questions you may have. And I might stop share and we can put back the title slide.
I'm curious, Lara, what nutrition food like supplement Are you using like Abbott, Nestle? What do you guys use?
Yeah, we have a contract with Abbott and we also contract with Cape Farms. So all of the Abbott products and I think, families sometimes really like to have kind of what kind of falls into this like all natural category or organic. And so for families like that, the Cape Farms tend to be um, favored.
I have a question.
Mhm.
As a professional, in a really specified, pretty unique clinical setting, um, could you explain how you continue to review literature and build comprehension around a lot of these subjects?
Yeah, I think I see such a broad range of conditions. And there are definitely common themes. And so, kind of knowing that I know how to initiate, I know how to advance nutrition support and just kind of basic skill building. But sometimes I run into things where I don't really know what to do. And so, we are encouraged to stay on top of the literature. We follow like ASPEN, the American Society for Parental Enteral Nutrition, and they tend to have really helpful consensus guidelines that can be a go-to. So just kind of knowing where to find the literature helps when we run into roadblocks. We talk a lot. We do clinical discussions as a department. And so if we have conversations about specific topics, we might end up having like a larger clinical discussion to really make sure that, as a department, we're on the same page. So for example, right now we're having ongoing conversations about how we want to assess DRIs. And there are big changes between the 2023 and 2003 DRIs that can lead to over or underestimating needs, depending on what seems to be the most accurate. So we've had just kind of ongoing debates as recently as we had a department huddle like 3 hours ago and are still talking about it. So a lot of like kind of talking to colleagues. We do our pediatric nutrition symposium, but we're encouraged to attend conferences. We have to maintain continuing education as dietitians. So finding topics that kind of relate to things that we see in practice. It's
Thank you.
ongoing. Yeah.
Thanks, Lauren.
I have another question. How have you like applied your bone research into what you're doing now with the dietary recommendations?
Yeah. I am very interested in vitamin D, and we have a vitamin D protocol at Children's. So patients that are admitted for a prolonged hospitalization are at increased risk of vitamin D deficiency. Part of that is just they're indoors, they have no sun exposure, but also if they have kind of any kind of dietary concerns or that loss of mobility manipulation. So one thing I really do is try to make sure that all my patients who've been in the hospital for over a month are tested, have their vitamin D level tested. And it's quite common if they're not already on like an enteral formulation that has adequate vitamin D, it's pretty common that their levels will come back low and we're going to supplement. And we have a protocol for how to approach that. I'm always really interested to see how people who have osteopenia are supported by the bone health clinic. I'm not really directly intervening, but I feel like I spend a lot of time reviewing their notes just because I'm curious about it. And then we have a metabolic bone disease of prematurity protocol. So I get patients that are stepped down from the neonatal intensive care unit, and they come to my facility for feeding therapy. And for patients that are premature, they and are born, before 36 weeks, they're really born before their body is really able to have peak bone mass accrual. The earlier they're born, the greater the risk of being born with osteopenia or prematurity is. And it can be really hard because they're not able to eat by mouth. They need to receive TPN for their nutrition. You really can't max out on calcium and phosphorus, which promote bone health because they form precipitates um, in the TPN bags. So there are a lot of barriers. And so I really like kind of working with that and kind of thinking through how we can kind of optimize their bone, but also kind of seeing where research opportunities present with that. There's a lot we don't know. So kind of satisfying my interest in nutrition, bone research that way too.
And then also, well, and especially like with parathyroid hormone or something
Mhm.
with like bone degradation or different hormones that just regulate bone health.
Mhm.
Are you able to look at that as well, or is that in like a different like
Yeah,
department?
yeah, I'm not really able to look at that. And I think, one limitation we do run into is that everything that we run in terms of labs ultimately has to be compensated. So if insurance doesn't cover it, and if it seems like it's an elective thing, they're not going to cover it, then that's out of pocket for the patient, which can be really limiting. And I can run into barriers with that. Like, I'd love to assess all the nutrition labs. Like, let's see what their status is. Um, but that tends to be denied by insurance. So, yeah, unless there's a patient enrolled in a research study that's funded, we're not really able to dig deep, unfortunately.
Thank you. It sucks
Mhm.
to know how little that like if patient health is funded, I
Yeah.
guess.
Yeah,
Especially
when
with
I
like
was,
hormonal levels or something like
yeah,
that's to determine different health
I agree. Although I
outcomes.
will say, if there is concern of hormonal issues of any sort, typically any kind of like whole system, body system is going to have like a specialist, right? So if there's a concern, they may be referred to endocrinology, and if there's a basis, then they would run those levels. So
Mm.
Um, there are options, but yeah, if I just had like a suspicion that's not really well founded, I'm not really at liberty to ask them to run something for me.
Oh, thank you.
Yeah. Yeah.
I'll ask another question. How could you explain more about how research is involved in your work as a clinician? And potentially specifically to enhancing medical devices and delivery of nutrients for a lot of the complex patients who might not be able to accept PO.
Yeah, I think any institution typically is going to have some sort of research going on, but as an academic institution, there's a higher focus on it. So we have a residency program, residents come through, fellows come through as well, who have like research requirements for their roles, and so they have to come up with some sort of research project, and that really definitely like is conducive to increasing overall research output. And so I had mentioned that there is a research committee. I'm sorry, my cat is back. There's a a research committee. So, if someone has a research study and they want a nutrition or dietitian to help with it, they'll reach out to us. And whoever among us is kind of interested and has the bandwidth to take it on, will sign up. And so for that, then it just kind of becomes like another part of the day, but the you know the science life cycle of like conception all the way to the actual implementation is gonna be a lot longer. So um, the research I'd be involved with really isn't at a point where it would lead to implementable interventions. But on the flip side, staying current with research, especially for my specific patient populations, is critical, right? So if I see something that has pretty good evidence to support, then I might consider it. And so I think one example, there are special formulas that are kind of touted as being like immune boosting that might have like glutamine and arginine in them. And there's not conclusive evidence to say, yes, give this to the patients that need something immune modulating. But there is starting to be more and more evidence out there to support using those for surgical populations. So um, sometimes I cross cover surgery, so maybe that would be a consideration. Like recommend this formula, A, because it's going to meet their nutrition needs, but B, there may be this added benefit. And it's not the sole reason I'm recommending this, but there may be this added benefit. And that's kind of where we might take research that isn't at a point of like clinical practice guidelines, um, but may help. So it should be another reason to kind of like support using it. But this certainly doesn't hurt either.
I'm gonna leave just anybody else, or not, I'm not leaving, but leaving time for one more question. We're nearly at the hour. Anything at all? Maybe not. Okay, that's totally fine. Laura, thank you again so much. This was really, really, really fantastic. I am going to stop recording and end the meeting if everyone wants to hop off. Yeah, thanks for joining us, and yeah, stay in touch.
Thank you.
Absolutely. You're welcome. And I think Adam had shared my LinkedIn. If anyone ever has questions or down the road wants to do like a rotation or something, um, happy to be in touch.